contained and accumulating within their ear canal. So based on that knowledge and also the fact that the patient is a very keen swimmer, although they do wear ear protection, I'm already believing this patient is suffering from otomycosis, a fungal ear infection, and I'll explain the reasons for that in a bit more detail. So the Optimized topical antibiotic spray contains 3 active ingredients. The first is dexamethasone, which is a steroid, it's anti-inflammatory, which the patient felt was working. It also contains acetic acid, so the acidity just helps to re-acidify the ear. When our ears are naturally acidic, between 5.4 and 7 on the pH scale, but often when they're infected, when you've got an outer infection, so otitis externa, which is what this falls under, the ear pH increases, it becomes slightly more alkaline. So if you re-acidify the ear by introducing acetic acid, it just helps the ear return to its natural normal pH, which can sometimes help to inhibit harmful bacterial and fungal growth. However, Optimize also contains an antibiotic, neomycin, and if this is a fungal infection, that antibiotic is not going to do anything, and in fact it can make it worse because the neomycin actually fights away some healthy bacteria in the ear, which then means that the fungus has got no competition. It's free to reign, it's free to colonize, it's free to reproduce and exponentially grow. And I feel this patient has got some candida, which is a strange fungal infection. The reason why I suspect that is this is quite thick and creamy discharge. More typically with a bacterial infection, the discharge is more less viscous, it's more prolix, more it's a bit more runny, a bit more less sticky and gooey like this. And I also think there's some fungal spores as well, so there could be some aspergillus and Nigel flavus contained, so I think there's probably multiple strains. So the idea is just to remove as much of this debris as possible. The eardrum is actually visible, believe it or not, it's there, remove the including debris, but this thick creamy discharge is coating the eardrum. It's probably the most difficult type of debris to remove because it is so gooey and sticky. We're going to try our best to remove as much as we can to reveal the eardrum, but also because it will then help any medication this patient is going to be prescribed by their GP to really make contact with the canal wall and eardrum and be most effective. So I've written to this patient's GP already and I've requested that the patient undergo a swab of the ear to really ascertain exactly what's going on, whether it's a bacterial or fungi, or a bit of both maybe, prior to being prescribed the appropriate medication. It's just as if they are again prescribed antibiotics, so this is a fungal infection. It's just going to make the situation worse. In the meantime, I've just recommended the patient to use some over-the-counter acetic acid spray for the ear, just to help to re-acidify the ear. And I've also recommended that they avoid swimming until this infection is cleared. So this patient's been suffering for several years, upon attending and really been struggling to hear. Because this patient also has some psoriasis, itchiness, what the patient was experiencing during the procedures, whilst after in the ear, they were developing itches in other parts of their body, which sometimes made it very difficult for the patient to remain still. They did brilliantly well. I always had one eye on the patient, so I was looking out for any sudden movements. It can happen. The first real case when I came across that was of my young nephew, who was 12 and was cleaning his ears out, and he developed such an itch on his knee, so some sort of involuntary response, that he constantly felt the need to scratch his ear, which would mean his body would move and his head would move. Ironically, I use a derma roller on my scalp, so I'm trying to prevent myself from going completely bald. So a derma roller, and when I use it on my scalp, I develop a runny nose and I get watery eyes. So again, there's some sources of nerves being initiated just by rolling a derma roller on my scalp, for me to experience this other organ side effects. The patient did brilliantly well. Really fantastically well. So the procedures make contact not only by the consistency, you can just see some of the eardrums now revealed. You can see that blue purple tinge, and this brown because it's laid over it. Now I've had to use some drops. I was trying to avoid the drops because obviously there is possibly some fungi in here. I've resisted the urge to use any olive oil because I was reading one of our audiological papers written by an ENT saying that if someone's got a fungal infection, it's best to avoid olive oil because that can exponentially make the infection worse because the fungi actually feed off the oil. So I just use some sodium bicarbonate drops. Now, sodium bicarbonate, yeah, it has got some water base in there, but it has got some antiseptic properties as well. It's just weighing up the pros and cons. So we just put some drops in, just as much as we need it, and backing it immediately, and obviously we're going to re-acidify the ear. Of course, this patient should not undergo ear irrigation in any circumstances because this is classified as otitis externa, so the patient has got otitis externa, and definitely should not go active ear irrigation or again avoid swimming and water activities. So what I'm going to do here is peel away this thick, creamy discharge and dead skin. So again, what's quite common with fungal infection, patients experience extreme psoriasis or itchiness of the ear. If you wait till the end, the patient sent a reply email because I forwarded a copy of the letter present to their GP. It's a lovely letter, and on that the patient also makes reference to their sister, who's a big fan, and the sister was great. I think she said she's watched all 1,400 of my videos now, and she's so fascinated to see it in person because she's only seen the videos, and the patient said the sister stood behind me, asked whether it was okay to film, and she said it was no problem whatsoever. It was quite nice because they had so many questions based on the videos which I could answer, clarify. And one of the things the patient sister said is that on screen these instruments look so big, but in reality, because they're in front of her, just how small and minute they are. So yeah, with an endoscope, it is magnifying I think tenfold on this. So in reality, this patient's ear canal, if I were to measure it, it's quite a narrow ear canal. They've got a bit of edema, a bit of swelling. I would probably say the width is about 0.4, 0.5 millimeters in diameter, so it's extremely narrow in width. And the height, as you can see, it is designed to be oval in shape, so the height is greater in the width, and of course about 0.7, 0.8 millimeters, which gives us very little wriggle room to work inside the ear. So what I'm trying to do here is just peel away some of this creamy gunk from the roof of the ear canal, the attic region. One of the other difficulties, you can just see it there, was having to constantly come out the ear and unblock the suction probe. I'm using the fine end suction probe here because we're working very deep in the ear, but because the patient's got a narrow ear canal as well. And this consistency of debris keeps blocking the tubes, and when suctioning it gets trapped inside, so it has to come out and this little threader that we have to sieve it through and feed it through to clear any blockages. Again, we've got to be really careful that we are working directly on the eardrum. The eardrum is around 0.1, 0.2 millimeters in thickness, so it's wafer thin, like a sheet of paper, probably a bit thinner. Because we're working with sharp objects, just got to be careful because one false move could quite easily rupture the patient's eardrum. And as I mentioned earlier, the patient was experiencing some itchiness other parts of their body, which was causing them to somewhat move on occasions, although they were managing it really well. Just peeling away from the front part of the ear canal. For me, this is the most sensitive part of the ear, so the inner 2/3, anyone new to the channel, the inner 2/3 is very sensitive. It's made of the bone, and we've got the thinnest layer of skin, 0.1, 0.2 millimeters in thickness, lining the bone. So if you make contact with that, the best probably thing I can compare it to is if you've got an exposed nerve due to a bit of tooth infection, and you have some cold ice cream or eat ice cold drink, that stinging reaction you get, it's extremely painful, and that's what it feels like if you bump into the bone with a bit of force. I know that myself because I've experienced some trauma in my ear before, so which in a way makes me well versed when I'm performing procedure because I can appreciate what the patient can feel if I do make some real bad contact with the bone part of the ear canal. So for me, just the front part of the ear canal is a bit more sensitive, probably because it's got a bit more blood supply there, so it's got probably a few more neurons there as well. Just trying to steady my hands. I think I eventually do get that. Of course, I could have probably left this the patient here really well already, but as mentioned before, because this has probably been there for a long time, and I just wanted to get as much out as possible, as safely as possible. So you'll see in the right side there's a point where when I finished, I could see the majority of the eardrum, probably on par with this, but I wasn't going to get any more out of it. It was a bit more stubborn on the right side, so I decided that's the right time. I made that clinical judgment to leave it. But whenever I feel I can, especially in case of infections, purely so it allows any ointment that the patient prescribed to make direct contact with the eardrum and the ear canal, so it's the treatment I receive is most efficient. So I'm just going to go to the bottom. This is the inferior portion of the ear canal and the eardrum. You can see the suction that's not coming right, so it's that thick wet mud. And again, I don't know how thick this layer is, so we've got to be careful with the suction because I don't want to embed it too deep because it very easily graze the full ear canal and so causing more trauma. When we cause more trauma, that's the last thing we want because that's going to make the infection worse. We start collecting up bruising the ear canal. Fungal, bacteria, whatever is going on here can enter those cuts and abrasions and penetrate deep into the ear and make the infection worse. Away from the eardrum. In a minute we are going to directly work on the eardrum. On the right side, I was in the eardrum quite a while actually. Because it's not stubborn. Now, in terms of fungal infections, they are less common than bacterial infections in here. Bacterial infections account for more or less, the statistics suggest 80% of infections is mainly fungal. The most common types of fungal infections are aspergillosis. So aspergillosis, they're normally easy to diagnose and recognise. You get hyphae, so there's polystrands, and you get fungal spores. They could be black, white, yellow appearance, or green. And then you get candida, so aspergillosis is probably 3/5 of fungal infections and more than 2/5 of candida, so that's a bit more difficult to diagnose, but they are more thick and creamy. Especially when I have a combination because some of it is thick and creamy and also have got some fungal spores. So this layer of dead infected skin is peeling off the eardrum. So just look how much cleaner already the ear looks compared to when the patient attended. And fungal infections are most common in human conditions. So when you go swimming, that can also introduce moisture, humidity, not really like a swimming can also develop swimming and bacterial. The fact that the patient's also got really dry skin at other parts of the body as well. I think it was the bowl of the ear, the outer bowl, we call it the concha bowl. They had really dry skin there. Today, when the patient came in on that particular day, it was on Friday, it was visible just how dry and tight and constricted the skin was. But that patient was always, that was a good day. And they also had really dry, tight skin behind the pillar, so behind the arteries of the outer part of the ear. And also they have it in the pit between underneath of the elbow. your lower arm, upper arm meet. So I'm interested there. Just that the anterior superior region, sort of northwest region here, the right arm. Again, this is a difficult region to access, especially in the left ear if you're a right-handed person. You've got to ensure you stretch the ear open, the endoscope, and then insert the instrument to gain access into it. Otherwise, the hinge will cross over, so it can be very difficult to see how dry thick this part is actually. I'm just peeling downwards. This patient had to return later on in the day, so our appointments are allocated for half an hour. Half an hour is for 99.9% of the appointments, more than adequate enough time. In fact, most procedures I perform completed within 3 or 4 minutes per ear. But I do allocate myself half an hour because you just don't know until the patient arrives what's more complex and what's not. We are seeing a lot more complex cases now from people in the UK. A lot of colleagues refer complex cases to themselves, so we do allocate the half an hour just in case, although often it's not required. But in this case, half an hour wasn't actually enough. I completed the left ear in the half an hour, and then I commenced with the right side and I was working on it for 10 minutes, and then there's a point in the right ear after removing the initial plug that I realised that is going to be equally as time consuming. We had patients already waiting outside, and I didn't want to rush. So left ear done, this is the patient's right ear. So the patient attended near the end of the day, and I just asked them if they were happy just to wait until after the clinic, and they're more than willing to do that, which is great. I just don't want to rush it. It is a delicate procedure, taking stuff at the canal wall and out of the eardrum. So although it's around 19 minutes, but those bits that I had to keep coming out, cleaning the inside of the suction probe, put the drops in, so it was half an hour in total in real time. So the right side, I was hoping initially it wouldn't be as bad, because they did say that I left it was the right side too, but in fact it ended up being a bit more complicated. So the Zola suction probe that we're using, the diameter is 2.1 millimeters. You can see that just about fits. Very narrow ear canal, slightly inflamed on this side, a bit more redder than the other side, causing a lot of edema swelling. And this is the point where I felt, I'm going to get this patient back, because just how creamy and thick it was going to be a bit of a tough job to remove. Feeling inwards, try and get as much of the skin and develop in one movement in a segment. Okay, so I think this is when the patient returned. When they did return, they were already saying how much better they could hear. So it really made a big difference. It has been affecting her quality of life. She mentioned that singers in Canada, it's been difficult to speak to someone on the phone. The TV volume's extremely loud. It's just generally people find it difficult to converse with the patient. So we're discussing long-term plans, because in my experience anyway, when a patient has a condition like this, it is generally chronic, and it's just about maintaining it. Once this initial infection is cleared, the patient is a keen concern, obviously we want to continue swimming, so just discuss some water protection. I guess we may put some custom swim plugs, they're custom made for the ear, so it prevents any water from entering. Acetic acid spray to help acidify the ear, and if it is a fungal infection, then advise that they don't use any olive oil, because that will potentially exacerbate their symptoms. So the patient is going to keep me up to date with regards to what they've been diagnosed with. and then we can come up with a good plan. They are, in my opinion, also going to need regular cleaning of ears, and this has been several years, so we've said about a year, and then we'll monitor it, and obviously they may need to attend a full year. So we're working directly on the eardrum. Again, I think this is candida, so fungal infection, there's possibly a few spores embedded, so there might be some aspergillus, and it's like sticky tape on the eardrum on the side. Sometimes when we do that, the skin starts to then peel off the eardrum and we can get it off in one piece, but it's just separated as we approach the eardrum. I think we're literally gliding on the eardrum, so the patient looks so well. I was again worried that in case they make any sudden head movements, it would be great. What the patient said they did is in the interval, because they were worried about moving, they were developing the itch on their forearms, so they just do some rubbing alcohol and rubbed it on the areas that they thought was itching. It really helped the patient. So just working on the roof of the ear canal, the superior aspect of the eardrum to the attic, and also the anterior recess to the right. There's a little widening of the ear canal. And we call that the anterior recess. So as we approach the eardrum, the ear canal narrows inwards, and about half a centimetre away from the eardrum, the ear canal it protrudes outwards again. So that creates a couple of recesses, one inferiorly at the bottom of the eardrum and the ear canal, called the inferior recess, with a little recess there, and one to the front of the ear canal, we call that the anterior recess. So without an endoscope, it's very difficult to visualise the anterior and inferior recesses. That's where the endoscope comes in its own. Because of the wide panoramic field of view at clients, we can see parts of the ear that it's not possible with a microscope or an otoscope. So as an audiologist, but during our training for 20 years, we never used an endoscope. And when I started to use an endoscope, literally back in 2015, it really changed the way I was able to diagnose patient conditions. It just increased my knowledge tenfold, because I was able to see things that I wasn't able to previously, and therefore give a better diagnosis. So the back part of the eardrum is more visible. It's still got all this gunk at the floor of the eardrum and this anterior. And just in comparison to the left side, the ear canal is a bit more puffed up, a bit more inflamed and swollen. Yeah, the frustrating part about this procedure is just the suction plug does take getting blocked. As you can see, I'm going to get in and out multiple times. So just put a bit more drops in just to help. But already the patient can hear really, really well on this side. And the whole ear canal is clear, it's just on the eardrum now. Just being a bit cautious, because I just don't know how thick this layer is. Again, as I advise there, the eardrum is way for thin. It's a lot of tensile strength, though, despite its thinness. But again, any sharp instrument can quite easily penetrate through the eardrum. So the eardrum is made up of 3 layers. The outermost layer, that's visible to us, is made up of the same skin that lines the inner 2/3 of the ear canal. It's the epidermis skin. More specifically, we call that stratified, which means layers, squamous, which means skin cells that are aligned like fish scales, or like pancakes, they're flattened. Keratinous, so the skin, as it dies, it produces the protein keratin. Epithelial, so the outer skin cells. So we call it together collectively, the outer layer of the eardrum is made up of stratified, squamous, keratinous, epithelial tissue cells. Then you've got the inner membrane of the eardrum, which is not visible to us, and that's made up of mucosa skin. So the mucosa, it's similar to the skin that's lining our nose, so it's more secretory and wet and moist. Mucosal skin shouldn't produce keratin. And then you've got the middle membrane, so the fibrous tissue. So the fibrous tissue on the main body of the eardrum is radially aligned and concentrically aligned, which gives the eardrum its strength and rigidity. On the top part of the eardrum, past the cedar, the fibrous tissue is more diffuse. So it's the thinner part of the eardrum, it's not strong. Hence why we call it the top part of the eardrum. Past the cedar, so it's more flaccid, and the main body of the eardrum is past tensor because it's not as strength. It's thick and creamy as this, and so all the residual stuff is actually just staining when you've got wet wax. And I showed the patient on the tissue and some debris, and see that it's wet and gooey as you're pulling along. It's just staining the eardrum, so it just wasn't possible to remove everything. But I've got the main debris out, which is the key. You see how I've just curled and bent the end of the fine end? And that just helps me to avoid the front part of the ear canal. I mentioned when I was performing the procedure on the left ear, the front part of the ear canal for me is the most sensitive. So I don't want to make contact with it. So by curling the end of the fine end, almost bending around the front part of the ear canal. So I can get access. Without that bend, I would be grazing that front part of the ear canal. Once more, I was hoping for it to suction up, but it didn't. It just blocked the end of the fine end. So this is the left back drops. Here, they're literally gliding. I'm making cut, kissing the surface of the eardrum and then moving the suction probe up. At the same time, I'm just getting my insect further and further in so I can get a better view and zoomed in, closer view. I've got a nice piece right there. This is the umber. You can see it's this bit is actually attached to the eardrum, but I managed to peel it away. So the umbo is where the hammer bone, which is the first of the three middle ear bones, is attached to the eardrum on the underneath side. It's almost like the bullseye of the eardrum, that's what I always compare it to. It's the centre of the eardrum. And it's just a bit anteriorly here, you can see, just trying to get the view, stretching it open. And this is the top part of the hammer bone, we call it the short process. Again, we'll be very gentle. I'm not sure if I'm going to get that, but again, I'm very pleased with what we've done already. Some people may not be, so I'm expecting possibly some emails. Yeah, if you just imagine that someone actually emailed me and a bit of a go at me for leaving bits and bobs, so we should see the inbox tomorrow. It's quite amusing actually. I think I actually just bent the fine end a bit more, so at this point so I can really get deep into the ear.